Assalamu alaikum. In this video, me and Ziad are going to be explaining the thyroid gland. I'll be covering the anatomy and histology part of the thyroid gland, and Ziad is going to cover the physiology part of the thyroid gland. Okay, before we get into the anatomy of the thyroid gland, we need to know what is the thyroid gland in the first place. So, the thyroid gland is a brownish reddish soft gland that covers the anterior part of the neck, or you could also think of it as the anterior part of the trachea. Okay, and it does not only cover this interior part, it goes like around the trachea, it like covers it around. It also weighs around 25 to 30 grams, which I don't really think you need to know. And you need to know that it's larger in women than in males. It's also surrounded by two layers, the true capsule and the false capsule. The true capsule is the layer that is in touch with the thyroid gland, and it's made out of fibrous connective tissue. Also, in histology, it's made out of dense irregular tissue. And the false capsule is the layer out that's not in contact with the thyroid gland, however, it's in contact with the stuff around the thyroid gland, such as the trachea. You could think of it like the pericardium of the heart, as we had the parietal layer and the visceral layer, the visceral layer being in contact with the heart and the parietal layer being in contact with the stuff around the heart. However, the difference is they're not continuous with each other. The true capsule and the false capsule is one layer of each. I also wrote here, it moves with swallowing. Now you might ask yourself, how does it move with swallowing? Because the false capsule is in contact with the trachea, during swallowing the trachea moves up and down, which also is the reason why the thyroid gland also moves up and down, because of the false capsule. Now, since now we know what's the thyroid gland, now let's talk about the parts of the thyroid gland. You have four parts of the thyroid gland. You have the right and left lobe, which you can see over here, and you can see they extend. They have very longer extensions where it goes from up and lower poles, and you have the isthmus, which is the part of the thyroid gland that connects between the right and left. It also, you need to know, it lies anterior to the second and third tracheal rings. And for the pyramidal lobe, it extends from, as you can see here, from the isthmus. It's like an extension of the isthmus, and it goes all the way up to the hide bone, which I'm going to show you a better picture after this slide. You also need to know that the upper pole of the right and left parts of the thyroid gland, they extend from the thyroid cartilage all the way down to the sixth tracheal ring. You really need to know that as kind of high yield as well. Now going back to the pyramidal lobe, you can see it extends from the isthmus and goes all the way up to the hide bone. So I guess I found this picture online and it helped me like understand it better. Now let's talk about the surface anatomy of the thyroid gland. Now the upper pole, as we said here, the upper pole of the right and left, they're near the Adam's apple, or you can also say the thyroid cartilage, and the lower border is near the sixth tracheal ring. So it makes sense, the upper pole with the middle of the thyroid cartilage or the Adam's apple, and the lower pole around the sixth tracheal ring. And the lateral borders, you need to know that you have the common carotid arteries. Note as well, to find the thyroid gland, palpate the carotids, which makes the lateral border of the carotid gland. So basically, if you want to find the thyroid gland, you need to palpate the carotid arteries, and once you palpate the carotid arteries, you'll be at the lateral borders of the thyroid gland. And for relations of the thyroid gland, there isn't much to explain, it's just all memorization, as you can see here. And there's also pictures here as well. You also need to know about the thyroid posterior relation. The posterior relations, the nerves are really important. Where here you have the superior laryngeal nerve, and also over here you have the recurrent laryngeal nerve. Now coming to the blood supply of the thyroid gland. You have, for the arteries, you have two main arteries supplying the thyroid gland. You have the superior thyroid artery and the inferior thyroid artery. Now, for the superior thyroid artery, it branches off the external carotid artery. As you can see here, the external carotid artery, and it's going to then later on branch for the superior thyroid artery, which is going to supply the upper pole of the thyroid gland. And it divides into anterior and posterior branches. Now, what's the clinical importance of the superior thyroid artery? Is very close to the external laryngeal nerve. And the external laryngeal nerve is important with the tone in the tensing of the voice. So that means if someone is trying to ligate the external carotid artery, they might injure, not the external carotid artery, the superior thyroid artery. They might injure the external laryngeal nerve, and injuring that is going to cause a monotone voice. If you want to know what's the monotone voice, is when the person can only speak with one tone. He can't change his tone. And that happens when there's an injury to the external laryngeal nerve. You also need to know external laryngeal nerve is a branch of the superior laryngeal nerve. Another very high yield concept that for ligating the superior thyroid artery, you ligate near the gland and not the origin. And if you want to ligate near the origin, that's going to be for the inferior thyroid artery, which we're going to get into right here. So the inferior thyroid artery is a branch of the thyrocervical trunk. And the thyrocervical trunk is then a branch from the subclavian artery. You can see here in this image, you have the subclavian artery, which is going to give us the thyrocervical trunk, which is then going to give us the inferior thyroid artery. As we said, from the name you can tell, inferior thyroid artery is going to supply the lower pole. And we said earlier that the superior thyroid artery is going to supply the upper pole. It's very self-explanatory from the names. It runs superior medially and posterior to the carotid sheath. And we said earlier, if you want to ligate the inferior thyroid artery, you need to be near the origin and not near the gland. So they're basically opposites of each other. Clinical importance as well. It's very close to the recurrent laryngeal nerve. Injury of the recurrent laryngeal nerve is going to cause hoarseness, and we took this from previous blocks. I also wanted to mention another important concept, that injuring the recurrent laryngeal nerve is much more significant. It's going to cause a much bigger difference than injuring the external laryngeal nerve, and we're going to have a question about that later on to have a better understanding about this point. Okay, now we have the thyroid IMA artery. It's not always there. It's only present in 10% of people, and its origin could be either from the aortic arch or the brachiocephalic trunk. The main thing that you need to know about the thyroid IMA, that it's the supply for the isthmus. So we talked about 3 supplies. One supply is for the upper pole from the superior thyroid artery. For the lower pole, you have the inferior thyroid artery. And for the isthmus, you'll have the thyroid IMA, which is present in 10% of the people. Now that we're done with the arterial supply, now we're going to talk about the venous drainage of the thyroid. Now we have 3 different three pairs of veins that drains the thyroid gland. You have the first one, the superior thyroid vein, which drains the superior pole, and it empties into the internal jugular vein. For the middle, it also empties into the internal jugular vein, but it drains the lateral parts of the thyroid gland. So it's pretty simple. For the superior pole, you'll have the superior thyroid veins, and you need to know that it empties later on to the internal jugular vein. Where for the middle thyroid vein, it drains the lateral parts of the thyroid gland, but it also then later on empties into the internal jugular vein. However, for the inferior thyroid vein, from the name, it's obviously going to drain into the inferior poles of the thyroid gland. However, it's going to empty into the brachiocephalic vein and not the internal jugular vein. Now we're going to talk about lymphatics. For lymphatics run in the interlobular connective tissue. So it runs through the interlobular connective tissue around the arteries, okay, where they communicate with the capsular lymphatic network. You have 3 main central nodes for the lymphatic drainage of the thyroid. First one, you'll have the prelaryngeal node, which can also be called the Delphian node. And the location of the prelaryngeal node is going to be in front of the larynx. The pretracheal node is going to be in front of the trachea. And the paratracheal node is going to be along with the tracheoesophageal groove. You can think of it as an order going down. Okay, now I feel like this is more important about the lymphatic flow, which is the lymphatic flow of the thyroid. You'll first of all start off with the thyroid gland, and from the thyroid gland, you're gonna have the superior thyroid veins emptying the lymph into the lymphatic flow, and then they're all gonna collect up to the deep cervical lymph node. at the deep cervical lymph node is then going to empty into the brachiocephalic node and then to the thoracic duct, I'm sorry. And sometimes, most of the time actually, it can directly go from the deep cervical lymph node straight to the thoracic duct, skipping the brachiocephalic node. Okay, that was basically it for the anatomy of the thyroid gland. I'm going to be going into the histology part of the thyroid gland now. But before we go into that, we need to like summarize some of the stuff, such as we have 2 lobes. I actually use 3 lobes because we also have the pyramidal lobe plus the isthmus, and then we have the capsules. And we said earlier they're dense irregular connective tissue. The septa divides the gland into lobules, and you can see here the septa, the white lines over here, is going to separate the thyroid gland into lobes. And the lobules contain follicles, which we're going to talk about later on in the video. And the septa, you also need to know that they carry blood vessels, lymphatic vessels, and nerves. And you have the thyroid gland, parathyroid. I'm sorry. And you're gonna have 2 superior. You can see it from the photo, from the image. Actually, you have 2 superior and 2 inferior. Okay, and from the histology slide, from Dr. Yaqin's lecture, we can see the follicles are like the circular spherical structures, and the septa is going to be the white line separating the thyroid gland into lobules. Now you can see here in the follicles, you'll have like a pinkish substance inside. This substance is called colloid, and the colloid is full of thyroglobulin, which is really important to know. Now the thyroid follicles. The thyroid follicle is a spherical structure filled with colloid, which we mentioned earlier. What is colloid? Colloid is a viscous gel composed of mainly iodinated thyroglobulin. And you'll know thyroglobulin more once Ziad explains it in the physiology lecture. For cellular components, they're lined in their normal state. They're lined by simple cuboidal epithelium. So if you ever get asked about what is the epithelial lining of the thyroid cells or thyroid follicles, you need to say it's simple cuboidal epithelium, and surrounded by them is the parafollicular cells. So they're in between the follicles, and I'll show you a picture later on to understand it better. And you need to know it's adjacent to abundant fenestrated capillaries. Why do you need fenestrated capillaries? So you can have them easily release, for example, calcitonin or iodinated thyroglobulin. You need fenestrated capillaries for that. Now for the functions, follicular cells, they synthesize T3 and T4, and they store them in the colloid. For parafollicular cells, they secrete calcitonin and decrease. What does the calcitonin do? It decreases blood calcium. That's it. I wanted to explain. You can see here you have the follicles. In between the follicles, you'll have the parathyroid. You see the spaces between them. There's not much here, but like the spaces between the follicles is going to be the parathyroid. Now let's talk more about the follicular cells. Actually, it's not talking more. We're gonna be talking about the epithelial lining. Follicular cells are normally, as we mentioned earlier, are simple cuboidal. However, if they are stimulated, they're going to appear as columnar. They're gonna transition and become taller and appear columnar. And once these follicular cells become inactive, they're gonna flatten and appear more squamous. And you also need to know that follicular cells have an apical vesicle, which helps transport and release thyroglobulin into the colloid. And we know from earlier, the colloid is filled with thyroglobulin, iodinated thyroglobulin. That was basically it for the anatomy and histology. It's pretty simple. Now I'm going to give you a few questions to test your understanding. A researcher is studying thyroid gland samples under a microscope. She observes follicular cells surrounding a lumen filled with eosinophilic material. What is the primary secretion found within the lumen? We said the follicular cells contains in it colloid, and the colloid is contained with the thyroglobulin, so the answer is going to be C. While performing a tracheostomy, a vessel supplying the thyroid gland severed, resulting in profuse bleeding. The vessel was ligated at the lower margin of the wound to stop the bleeding. Which of the following was most likely severed in this case? In this question, it's talking about a tracheostomy. The tracheostomy, it happens in the medial margin of the thyroid gland, which means, and we know earlier, which of these arteries are going to supply the medial part of the thyroid gland is going to be the thyroid IMA artery, which is going to supply the isthmus of the thyroid gland. So the answer is going to be A. A woman had a subtotal thyroidectomy. A structure close to the superior thyroid artery was damaged. And what will she experience? Now, before we answer the questions, we need to understand what is close to the superior thyroid artery. We mentioned earlier the superior thyroid artery runs along with the external laryngeal nerve. The external laryngeal nerve involves with the changing in voice quality, and we said an injury to that is going to cause monotone. So the answer is going to be A. Which cells secrete a hormone responsible for decreasing blood calcium levels? We said for calcium, anything that has to do with calcium, you'll think of parafollicular cells because they release calcitonin, and calcitonin is going to decrease calcium levels in the blood. A 40-year-old patient was diagnosed with hyperthyroidism and scheduled for a subtotal thyroidectomy. Paralysis of the vocal cords can be prevented by securing which of the following structures away from the lower pole of the gland. Now, initially you might be thinking of the nerves, but however, it's talking about which structures away from the lower pole of the gland, and also it's talking about a thyroidectomy. A thyroidectomy is going to be ligating one of the arteries, so it can't be any of the nerves. So that means the answer is going to be D, inferior thyroid artery, because we also mentioned it's the lower pole of the gland, and we know from earlier the lower pole of the gland is supplied by the inferior thyroid artery. Which nerve damage leads to weakness of the voice? Okay, for this question can be a bit confusing because you could be stuck between either A and B. However, I mentioned earlier that for A, recurrent laryngeal nerve is for much more serious cases. So that means A can't be the answer, and the answer is going to be B. Because in the question it only mentions weakness of the voice. Weakness of the voice such as a monotone, which is going to be caused by the injury of external laryngeal nerve. Recurrent laryngeal nerve is going to cause much more serious issues later on. That was basically it for the anatomy and histology part of the thyroid gland. Now Ziad is going to give you the physiology of the thyroid gland.
Alright everyone, I believe Khaled just finished his anatomy and histology. Now let's move on to physiology. So in physiology we're going to talk about the secretion or the synthesis of the secretions of the thyroid gland. So the thyroid gland, to be specific, the follicular cells of the thyroid gland synthesize T3 and T4, which is triiodothyronine, and T4, which is thyroxine. 7% of the synthesized thyroid hormone that the follicular cells synthesize is going to be T3, while the other 93% is going to be T4. T4, once it goes to the target cell or target tissue or whatever you want to call it, gets turned back into T3 because T3 is technically the active form by 5' deiodinase or just deiodinase. The function of T3 and T4 are the same, but they differ in rapidity and intensity of their actions. The differences between them. T3 is 4 times more potent as T4, so T3 more active, more potent than T4 by 4 times. Even though it is more potent and more active, it lasts shorter and has a shorter half-life, so it lasts shorter in the bloodstream. T3 has 3 iodine and T4 has 4 iodine for the name T33, T4 4. And here's the third secretion that we're not going to be talking much about it, but calcitonin. The thyroid gland also secretes calcitonin, which decreases the calcium in the blood. It is secreted by the parafollicular cells, not by the follicular cells. Our main focus is going to be follicular cells. But I believe Khaled, mentioned the parafollicular cells. So, parafollicular cells, they're the ones that secrete calcitonin. Now, Khaled already talked to you about the physiological anatomy, or just the anatomy. Follicle with the follicular epithelial cells. Cuboidal has the colloid here. Main constituent of the colloid is thyroglobulin, and thyroglobulin has a lot of tyrosine residues, and it is the precursor of the thyroid hormone. Now, let's talk about the role of iodine in thyroxine synthesis. Now, we need 1 milligram of iodine per week. and it gets absorbed by the intestine similar to chlorine. So whatever amount, whatever way or mechanism that we absorb chlorine, we also do that for the iodine. Okay, so obviously we're gonna have iodide, circulating in the blood. 20% of that, or a fifth, is gonna get absorbed by the thyroid gland, while the other 80 gets removed by the kidney. Now, how does the thyroid gland absorb it? Now, there's a mechanism that the thyroid gland performs, which is iodide trapping. Iodide trapping is basically the concentrating the iodide into the cell at about like 30 times more than it is in the bloodstream. How does it do that? It has this symporter called the sodium iodide symporter, or NIS for short. It is found at the basolateral membrane. Please remember the basolateral membrane. NIS, basolateral membrane. Alright, because we'll specify where each channel is found. What it does is that it gets one iodide in and gets a co-transported with two sodium. So both of them go in. Now, what inhibits it? We have perchlorate, thiosinate, and nitrate ions. 888. So 888, they inhibit NIS, or iodide trapping. Now, if we keep absorbing sodium and, with iodide we go and do the thyroxine synthesis, but with sodium, we do nothing with it. So how do we, stop sodium from increasing in the cell and inhibiting NIS, or interfering with the function of NIS? We have ATPase pump, the sodium potassium pump, or ATPase, whatever you want to call it. The sodium potassium one, it just makes sure that we have low intercellular sodium and pushes it to the extracellular space or into the bloodstream. Now I'm gonna explain the synthesis of the thyroid hormone on this, and I'm gonna have it written later. If you don't understand it from my explanation, you're gonna see it written, you're gonna be able to, read it and go over it at your own pace. So, let's start with the formation of a protein called thyroglobulin. It is not really, part of the synthesis of thyroid hormone, but it plays a role in it, so we're gonna talk about how thyroglobulin itself is synthesized. So we have this endoplasmic reticulum, specifically the rough endoplasmic reticulum, the one with the ribosomes. That's the one that's gonna make the protein. The protein is then gonna go to the Golgi apparatus, and in Golgi it's gonna be a thyroglobulin precursor, which then goes to the colloid and becomes thyroglobulin. Alright, now let's go back to the cell itself, the follicular cell. Here we have the apical membrane, which faces the colloid, and here we have the basal membrane, or basolateral membrane, which faces the bloodstream. We have two channels here. Obviously, the sodium potassium one, it can be found anywhere, not just basolaterally, but the NIS is only basolaterally. We already mentioned what it does. One iodide in and two sodium in. This sodium potassium ATPase ensures that we have low intercellular sodium. This iodide goes to the apical membrane where we found pindrin. Pindrin is gonna make sure that iodide goes into the colloid or into the follicle, and chlorine is gonna go into the follicular cell. So it's basically gonna counter transport iodine and chlorine. Chlorine in the cell, iodine into the colloid. It's a chlorine iodide counter transporter. Now that we have iodide, it's gonna get oxidized into iodine or nascent iodine by peroxidase using H2O2, or it is activated by H2O2. And this same enzyme is gonna make sure that iodine, the new nascent iodine, is gonna bind to the tyrosine of thyroglobulin. This process is called iodination, which forms MIT and DIT. And this same enzyme is gonna make sure that MIT and DIT go through a coupling reaction, which is gonna help form T3, RT3, and T4. T3 is formed when one MIT and one DIT are coupled together, and T4 is formed when two DITs are coupled together. Now that we have this thyroglobulin with all of these MIT, DIT, T3, and T4 on it, it's gonna go through pinocytosis, which is a form of endocytosis, but we have, pseudopods. It's gonna go in. Now we have a colloid droplet. Colloid droplet is gonna get, we're gonna hydrolyze the T3 and T4 from this colloid droplet through proteases found in the lysosome. And T3 and T4, they're lipophilic, so they're gonna be able to go out of the cell into the blood through what? Through simple diffusion. And when they're in the blood, since they're lipophilic, they cannot stay in the blood. They hate the water. Okay, right? So they're gonna be bound to either thyroxine binding globulin or into thyroxine binding prealbumin or albumin. And then the MIT and DIT, what happens to them? Three-fourths of them, they just stay, they're still bound to the thyroglobulin, and they go through deiodination, and they produce what the iodide and tyrosine. There also another thing that you can call the MIT and DIT is iodinated tyrosine. So they're iodine and tyrosine. So when you deiodinate them, you're going to be left with you're going to recycle them back into tyrosine and iodine. And that's basically it for the synthesis of thyroid hormone here. This is basically what I just said, very simplified into words. First step, already mentioned it. What I need you to focus on that I did not mention is that thyroglobulin has 70 tyrosine residues, and iodine, not iodide, with an N, binds to these tyrosine residues. At basal activity, it concentrates 30x, but then it doesn't. But I also mentioned that, but I'm gonna mention it again. We need to emphasize these things. Second step, we talked about this enzyme, peroxidase. It is inhibited by propylthiouracil and two other things that I'm gonna mention later. It oxidizes iodide into nascent iodine, and this binds to the tyrosine residues on in the thyroglobulin. Peroxidase doesn't only oxidize iodine, but it also catalyzes the binding of oxidized iodine, which is organification or iodination, to 1/6 of the tyrosine in the thyroglobulin. So not all of the tyrosine gets, bound to the iodine, but 1/6. After that, we have the organification and iodination, which is catalyzed by peroxidase. Simply bind the iodine to the thyroglobulin. That's organification. If you have one, we form MIT. We have two, we have form DIT. After minutes, hours, or days, these DIT and MIT, they go through coupling reactions to form T3, T4. T4, we mentioned before, 2 DIT, T3, 1 MIT, 1 DIT. After, they get coupled together. Now, for T3, if we have, instead of 1 MIT, then 1 DIT in the chemical structure, as you can see here, this is MIT since it has 1 iodine, this is DIT since it has 2 iodine. If we have 2 first, then the 1, we're gonna form our T3, reverse T3. The 1 thyroglobulin stores 30 thyroxine or 30 T4 into few T3, but the amount that the 1 thyroglobulin stores can last, for 2 to 3 months. Alright? Try to keep that in mind. They might ask you about how long does it last. If you have 1 thyroglobulin, how long does the hormone it contain last, or the effects of them last? 2 to 3 months. Now, releasing the hormones. We said that the thyroglobulin itself is gonna go through penocytosis through the apical membrane. It itself, it's not gonna get released into the blood in measurable amounts. It's gonna get proteolized by proteases in the lysosome to let go of T3 and T4, so they can go through simple diffusion. Three-fourths of DIT and MIT, they do not get released from the thyroglobulin. They're also called iodinated tyrosine, but they stay bound to it, and through deiodinase, they become tyrosine and iodide in the cytosol. Now, if the patient has absence of deiodinase, it would lead to thyroid hormone deficiency since we cannot recycle. Now, let's visualize it. Here it is, if you need to go through the steps with yourself again. But I have to explain this HPT axis. The hypothalamus, anterior pituitary, and thyroid follicular cells, or thyroid gland. The hypothalamus itself has this hormone that releases from the median with an N, eminence. It releases TRH, which then binds to the G-coupled protein receptors in the pituitary gland and goes through the mechanism of PLC, phospholipase C. Phospholipase Z goes and hydrolyzes PIP2 into IP3 and DAG. IP3 increases calcium, and then that causes us to have two secondary messengers. One of them is DAG, the other one is calcium. These they activate phosphokinase C, which then phosphorylates proteins in the anterior pituitary gland and cause the secretion of TSH. Now that TSH is secreted, it will go and bind to its receptor on the thyroid follicular cell. It goes through another mechanism that I'm gonna mention later on, and it increases T3 and T4. Now, I want you to think of this as a downstream effect. It's a waterfall. شلال. If you get a disease here, let's say pituitary cancer, adenoma, you're gonna have an increased TSH, and that will also cause an increase of T3, T4. Now, using the same concept that I just, mentioned, you can go back, listen to it again, and then come back to this part. If the patient comes to you with hypothalamic adenoma, you should expect increase of TRH, increase of TSH, and increase of T3, T4. One thing I forgot to mention about, anterior pituitary adenoma is that the increase of TSH, it's gonna have a negative feedback effect on the hypothalamus and the secretion of TRH. So we would have low TRH in the case of anterior pituitary adenoma, and we'd have high TSH and high T4. So basically, whatever is above the affected part decrease, whatever is under is gonna increase. That's if it's cancer. That applies to cancer, not to inflammation or deterioration. Okay? Now, based on the concept that I just explained, a patient comes to you with high T3, T4, but low TSH and low to normal TRH. What organ or what gland do you think is affected? Again, high T3, T4, low TSH, and low to normal TRH. I believe if you've understood the concept, it should be thyroid follicular cell. We mentioned again, it's the damaged one, or the affected one by cancer. It's gonna increase what's after and decrease what's above it because of feedback inhibition. So we would have high T3T4, less TSH, and low to normal TRH. I do not really know why TRH would still be normal after this, but it was mentioned that it can be normal. Now, let's go towards thyroid hormone action. Binds to the plasma protein, as we said, the thyroxine binding globulin, and that's the main one that it binds to, and then less than that to the thyroxine binding prealbumin and albumin. T3 and T4 get released into the tissue cells, with T3 having lower affinity to the plasma binding protein. So T3 sticks less to the proteins, which means that they'll be easier to release. Alright, T3 has lower affinity to the proteins, they'll be easier to release and they'll release faster. That's why it makes sense for half of T3 to be released every 1 day and half of T4 to be released every 6 days. Keep the concept of lower affinity in mind. You're gonna find that very useful when it comes to questions about these, and you will not need as much recall as you need understanding in this concept. Now, in the cell itself, we already talked about the plasma proteins. Same concept applies to inside the cells. The T3 and T4 they bind to proteins, so they can be stored and slowly released whenever, within days or weeks. The T4 binds stronger to the proteins, so they're probably the ones that take weeks, and T3 takes the ones, in days. Now, let's talk about the hormones, T4 and T3, via injection. Now, the injection has two effects, pharmacokinetic effect, which is immediate, and the pharmacodynamic effect, which has the latent period that I'm going to talk about. Now, let's start with the pharmacokinetic effect. It basically means the levels of the hormone. So, logically, if you take an injection of the hormone, the levels of it, they're gonna increase immediately, or in 1 to 2 hours. That's still considered immediate effect. That's what we call pharmacokinetic. But the pharmacodynamic, it's about the effect of the hormone itself on the body. It's about the metabolic effect. That one has a latent period, and this causes, the injection, it starts immediately in a in the pharmacokinetic point of view, but it takes time to peak in the pharmacodynamic effect. All right, let's talk about T4. We said T4 is the less potent one, so it's gonna have a higher latent period or a longer latent period. T3 is gonna be 4 times more potent or more active. So T3's latent period is 6 to 12 hours, while the latent period of thyroxine or T4 is 2 to 3 days. All right. For the maximum or peak activity, thyroxine takes 10 to 12 days, to reach to the you know peak activity, and it has a half-life of 15 days. So after 15 days, it will start decreasing. So generally, that means T4 can last up to 2 months. So it lasts so long, and considering what we mentioned about T3 is that it has a shorter half-life and it lasts shorter. Now we mentioned that T3 is 4 times more active. So if T4 takes 10 to 12 days to peak, divide that by 4, you're gonna get 2 and 3 days. I know 10 divided by 4 is 2.5, but خد نعقد عقلي, you know, allow me to just say it's 2. It peaks after 2 to 3 days. Alright? Keep this very clear. They might really ask you about that. And make sure you know that T3 latent period is in hours, not days. 6 to 12 hours. Now let's talk about the physiological function of thyroid hormone. How does it work? We have here T3, T4. They're lipophilic. They go through no problem diffusion. T4 gets converted into T3 by deiodinase, and now they just go and bind to their thyroid hormone receptor, which is a nuclear receptor. Once they bind to this receptor, they activate the retinoid X receptor. That this part will be activated. It will go and bind to the retinoid X receptor. This complex will go to the thyroid hormone response element. It will activate gene transcription of many genes, and it will increase the amounts of proteins and enzymes produced. What would this have? It will have all of these effects. Growth is going to be increased or affected. The CNS, based on myelination and everything, is going to be affected, or we're going to have more development of that. Cardiovascular hemodynamics will have more heart rate, more cardiac output, more blood flow, more vasodilation, will have more stroke volume, will have more heart contractility. The metabolism will increase, and it will increase body temperature. Obviously, we cannot just magically increase the cardiovascular hemodynamic and the metabolism. The increase of cardiovascular hemodynamics and the metabolism uh, حتكون على حساب the respiration. There'll be a subsequent effect on respiration, so we'll have an increase of respiration due to the O2 consumption by metabolism and cardiovascular hemodynamics. So let's talk about the function and effects of the thyroid. You already mentioned that briefly. Brain, 7Bs, brain maturation, CNS. Bone growth, we already talked about the effects of growth. It works with GH. Beta adrenergic effect is basically the cardiovascular hemodynamics. And these effects, they're, alleviated by beta blockers. The BMR, the metabolic rate, it's gonna increase through the sodium potassium ATPase. We're gonna have more of that increased, and we're gonna have more mitochondrial activity increased, which will increase the O2 consumption and therefore increase respiration. We'll have more blood sugar levels, so we'll have an increase of glycogenolysis. We'll, break down glycogen, and we'll have gluconeogenesis, which is formation of the glucose or forming glucose. We'll break down lipids, so lipolysis, such as cholesterol, phospholipids, triglycerides, and in babies, will stimulate surfactant synthesis, which prevents the lung from collapsing. For the breakdown of lipids, it's very important because if we don't break down cholesterol and the other lipids, we could be facing, higher risk of atherosclerosis, peripheral vascular disease, and many others that I'll mention later. Basal metabolic rate, you might see a question and be like, what does this point, what does it describe? What does a point here describe? What does a point here describe? Basically, we have a plot of the basal metabolic rate change or change in the basal metabolic rate. So it is not the basal metabolic rate itself, it is the change in it. So if it was normal, there should be no change. That's why you'd find that at 0. And what level of, or what, amount of thyroid hormone is necessary to keep it at normal. Now, obviously, that changes with weight or, height and weight. But, normally 70 kilogram person with, I don't know, average height, he's gonna need or she's gonna need 100 milligrams per day. I believe it's gonna be a person, of 70 kilogram male. They're gonna need a 100 milligram per day of thyroid hormone, and that will maintain the normal. If you have less than 100, we'll have a decrease in the basal metabolic rate. So if it's at -10, if it's right here, That means we have 90% basal metabolic rate. If it is right here, we'll have an increase of 10%. So that's 110% of the basal metabolic rate. All right, so the change is 10 here. The change is minus 10. Decrease, increase in the basal metabolic rate. 0 is normal, not that it's none. Thyroid effect. We already talked about this. We talked about this. Now let's focus on the bodily mechanism. We said that it increases blood sugar. So we'll have an increase in uptake of glucose, increase in glycolysis since we take more glucose, and gluconeogenesis to form glucose. And if you want to maintain the uptake in glycolysis, since we have high blood sugar, we're gonna need more insulin secretion. So the thyroid hormone also incorporates the endocrine pancreas or the endocrine part of the pancreas to work with it by making it secrete insulin. And another thing I'd like to mention here in the development of bones, we're gonna be using parathyroid hormone to work with us and help us in bone formation. Now it increases lipolysis, so we'll have less fat, less cholesterol, less phospholipid, less triglyceride, and we'll have an increased expression of LDL receptors, which is going to help us remove LDL from the plasma, and secretion of cholesterol by the liver is going to also be decreased. We're gonna need more vitamins to make these enzymes, to keep the enzymes functional. Enzymes need vitamins. Here we have the effect of thyroid hormone. Quickly, gastrointestinal motility, that's going to be increased. So more appetite, anything you can think of from GIT, that's probably going to be correct. CNS is going to be excited. So anxiety, sharp anxiety, مثلا, paranoia, extreme worry, that's all going to be increased or excited. The muscles. Now, short term, the muscle reaction is going to be increased. You're going to feel like a Formula 1 driver or F1 driver. But long term, they're going to get weak because they're not getting rest. You're going to go through muscle tremors, which happens due to the increased activity of the synapse or synaptic ends of the spinal cords controlling the muscle contraction. And this increased activity, it's going to it's going to make you feel fatigued, and it's going to make you not sleep since it's excited. So it's like the most evil thing ever. It makes you tired, but it doesn't let you sleep. Now, in hypothyroidism, you're still tired because you don't have muscle reaction now. You're feeling sluggish, but at least it lets you sleep very long, too long to be honest. You do not need to be sleeping 12 hours or more than half the day. Now, the effects of this hormone on the endocrine gland, we already mentioned the pancreas, we already mentioned the parathyroid due to bone formation, and the pancreas due to the glucose uptake and insulin secretion. One thing we did not mention is that the liver, it would affect the liver by accelerating the inactivation of adrenal glucocorticoid. So the inactivation of adrenal glucocorticoid is increased. Uh, Due to that, we'll have an increase of ACTH by the pituitary gland, which will increase the secretion of glucocorticoids by the adrenal gland. So pituitary gland, it is stimulated by this inactivation, have ACTH. ACTH works on the adrenal gland, and now we secrete glucocorticoids. So for endocrine glands, pancreas, parathyroid gland, uh, pituitary gland, and the adrenal gland. Now in sexual function, hypothyroidism decreases libido. Hyper causes erectile dysfunction or impotence. Hypothyroidism on women, it causes frequent menstrual bleeding. So bleed too much, irregular bleeding, irregular periods. Same thing with bleeding. That means instead of getting it every month, which is the normal, let's say you get it 1 month, skip the other, get it again, or skip 1 month, get it again, or get it 3 times in the same month, or even no periods at all, amenorrhea, not menopause, amenorrhea. Okay? Now on the gonads, it's gonna have a direct metabolic effect, and it's gonna be regulated by the feedback regulation by the anterior pituitary gland. Now, we already talked about the regulation, but let's talk about TSH itself. It's a glycoprotein that increases TH. How does it increase TH? It increases it by increasing every step or stimulating every step of TH synthesis. proteolysis, pump activity, iodination, size of the gland, and secretory activity, the number of the cells, and it'll change the cells from cuboidal to columnar. I believe it should be mentioned in Khaled's part, but I'll mention it here again. It's normally cuboidal. Once it's stimulated, it's columnar. If it's inhibited, it is simple. Or squamous, not simple. TRH effect on the pituitary. We already mentioned that median eminence. You can read this for yourself. I've already mentioned all of this when I went through the downstream effect and explained it all. You can go back and listen to my explanation. The mechanism of TSH, we're gonna talk about how it works. It activates adenyl cyclase once it binds to its receptor. That increases cyclic AMP, which is the secondary messenger. That activates phosphokinase A or PKA, which phosphorylates many proteins and causes the secretion of TH, thyroid hormone. And also it will cause the prolonged growth of thyroid glandular tissues. Please, please, please remember that TSH causes prolonged growth of the thyroid glandular tissue. Now, T3 and T4, they have negative feedback effect on the secretion of TSH. So if you have an increased T3, T4 level, naturally, we're gonna have low TSH. When is TSH stimulated? When we're cold. When is it inhibited? When we're anxious or excited. If the thyroid hormone, mainly T3, is 1.75 fold its normal concentration, so we just, multiply it with 1.75, the TSH level will decrease to 0. So it doesn't even need to be twice as, what's found in normal concentration. It's just 1.75, so 75% increase. Now let's talk about the pharmacological control of every step. For iodide trapping, it's inhibited by the 8s, thiosinate, percholate, nitrate. How does it do that? It competes with iodide at pump level and it causes goiter. Goiter is basically hypertrophy of the gland due to the increase due to, it's a result of less T3, T4, which increases TSH, and then TSH has the effect of growth on the glandular tissue and increase of thyroglobin. The organification of tyrosine and coupling of DIT and MIT, that is done by PTU, which is propylthiouracil. That's going to be mentioned a lot, should be easy to memorize. And we have the zoles, Sudanian, methimazole, carbimazole. Just memorize them as, zole, they go for the organification of tyrosine and PTU. How do they do that? We said that one enzyme does both of them, peroxidase, and that also causes goiter, which is explained above. Punicytosis and endocytosis, that's the mechanism of, reabsorbing the, into a colloid droplet. How is it inhibited? Due to high iodide concentration, about 100 times. The activity of the gland is decreased, so we don't, we decrease the iodide trapping by decreasing the activity of the whole gland, and that causes paralysis of the pinocytosis, which leads to a smaller thyroid gland. That effect is called Wolff-Chaikoff effect. Now, hyperthyroidism. Hyperthyroidism, we have two diseases associated with it. Autoimmune disease, which is Graves' disease. It's an autoimmune disease where we have high T3, T4 from the name hyperthyroidism. The antibodies bind to the TSH receptor and mimic its activity. And since we have high T3, T4, we're going to have TSH near 0 or very low. Here we have thyroid adenoma. It is basically cancer in the thyroid gland. It does not involve TSI. It will cause enlargement of the gland and will have less TSH and high T3, T4. The cancerous region will keep secreting the thyroid hormone while the healthy part secretes less due to less TSH. One of the things that Graves' disease cause is, thyrotoxic cytosis, which is just excess thyroid hormone in the blood. It's a symptom, not a disease. Now we have the exothalamus. It looks scary, but we're gonna make it very brief. Exothalamus just means protrusion of the eyeballs. Eyeballs are more out. It happens in people with hyperthyroidism. How does it cause it? It causes swelling of the retroorbital tissue, so the tissue under the eyes, or not under the eyes, behind the eyes, is gonna swell, so it's gonna push it out, and the extraocular muscles, the ones in front of the eyeball, they're gonna degenerate, making it look even more protruded. People that have exothalamus usually have high TSI since the immunoglobulin G reacts with the eye muscle. So it's usually found in these people. Not that it's a condition. It's basically, statistically, it's more found in these people due to IgG's reaction with the eye muscle. Now, to diagnose exothalamus, measure the free thyroxine in plasma. يعني يمكن واحد هيك protrude, he has his eyeballs protruded هيك from, born with it, خلقة من الله. So to diagnose it, you have to measure the free thyroxine in plasma. Make sure it's gonna be high if the patient has exothalamus. BMR should be increased if the patient has exothalamus to 30 to 60 plus, so 130 to 160% of normal. The plasma level of TSH should be 0 or close to 0. TSI levels, if the TSI levels are high, then that's gonna tell you the cause of the exothalamus is thyrotoxicosis, so it could be Graves' disease. And if it's low, it could be an indicator of thyroid adenoma. So two things that cause hyperthyroidism, and we're gonna differentiate between which one of them using TSI. To treat hyperthyroidism, just remove the thyroid gland, and before you do that, make sure you give the patient PTU for 1 to 2 weeks to decrease the basal metabolic rate. Another option, if the patient does not want to go through the surgical path, is radioactive iodine. It'll be 90% of it will be absorbed within 1 day, and it'll destroy the cells. It's gonna be mainly absorbed by the hyperplastic cells. If the patient still shows hyperthyroidic symptoms, give the patient more doses or more of the dose. Now for hypothyroidism, Hashimoto's disease. Hashimoto's disease is another autoimmune disease, but we have the antibodies attacking the gland and deteriorating it. It's gonna give a fibrosis or size reduction to the thyroid gland, and it's gonna cause inflammation. We'll have less T3, T4, and high TSH in it. For the endemic Khaled goiter, endemic basically means dietary. So any dietary related issue is خلاص dietary iodine deficiencies endemic Khaled goiter. You're gonna find endemic in any dietary thing. Since it's hypothyroidism, high TSH, and it's goiter, so hypertrophy of the thyroid gland. It doesn't make sense. Why do we have a bigger gland but low low T3T4? It is because we have the deficiency of iodide. We cannot form the T3T4. We have high TSH. The high TSH increases thyroglobulin, increases grows the glandular tissue. Now for the idiopathic non-toxic Khaled goiter, it's gonna be due to thyroiditis, and it's gonna have a nodular shape. Thyroiditis is the infection of the thyroid gland. The size in some areas is gonna decrease due to the infection, and we'll have less T3, T4, and more TH due to the decrease of T3 and T4. This is gonna make the non-inflamed area or the healthy area respond to the TSH, grow, and the thyroid gland is gonna look more nodular. Now here's hypothyroidism. We talked about the Khaled goiter. It's related to the enzymatic system. So peroxidase, it's gonna be a problem. Deiodinase is gonna be a problem, and these two, they're basically one of the steps. They're gonna be deficient in hypothyroidism. Goiterogenic substances. They're gonna include propylthiouracil or any anti-thyroid activity. Like let's say patient comes to you, this dude eats too much cabbages, bro, and turnips. He's going on a diet full of cabbages and turnips. You're a turnip, bro. Don't you know that they have goiterogenic substances? Like, okay, so على طول, cabbages, turnips, propylthiouracil, goiterogenic substances, they cause hypothyroidism. Now, symptoms of hyperthyroidism and hypothyroidism. Hypo is opposite of hyper, except for the fatigue part. Both of them have fatigue, but one of them you cannot sleep, the other one you sleep for too long. High state of excitability, we said that it's going to increase the activity of between in the synapse of the synaptic cords, which is going to increase the excitability. More metabolism, so intolerance to heat. More sweating to cool off, thus increase of heat. Extreme weight loss due to the increase of BMR. Diarrhea, I don't know why, but you get diarrhea with hyperthyroidism. You get muscle weakness due to the prolonged effect of of the hormone on it, since it increases its reaction. Nervousness, it causes anxiety, paranoia, and all of that to the CNS, so it causes nervousness. Fatigue with inability to sleep and tremor of the hands. It is exactly the opposite in hypothyroidism, but I want to emphasize myasthenia. It is edematous appearance throughout the body. It's basically you're looking at someone full of fluid, edema, okay? And depressed growth. And these hemodynamic effects or cardiovascular hemodynamic effects, they're going to be decreased. Now, to treat hypothyroidism, just supplement thyroxine, give the patient the hormone, and then they'll continue normally after that. Patients with hypothyroidism, they'll have less lipolysis, which means more fat, more cholesterol. That will put them at a higher risk of what? Of atherosclerosis, peripheral vascular disease, coronary artery disease, and that could cause early death. Another thing that hypothyroidic patients suffer from is deafness. We're going to talk about myxedemia and not thyroid adenoma, but cretinism. Myxedemia, absence of the thyroid hormone function. It is absent. You'll get bagginess under the eye and swelling of the face. So instead of the eyes poking out, you'll have the under eye region, it's going to be baggy. It's going to be pushed out. How does it work? The hyaluronic acid and chondroitin sulfate, they're GAGs, they bind to proteins, they go into the interstitial space, and the fluid is going to follow. The hypothyroidism, we mentioned that before, it's impaired metabolism fat, causes atherosclerosis. And now for cretinism, cretinism is only in the newborns. A 60-year-old patient comes to you with hypothyroidism. Which of the following does he have? If you pick cretinism, you're just not listening to the question. It says 60 years old. So it's only in fetal, infant, and childhood. So any little kid, baby, anything like that. And another characteristic that these patients have is that they're obese, stocky, and they have a short appearance. They're built like a block, basically. Causes for that can be genetic or dietary. If it's dietary, back to the point that I mentioned, is going to be endemic cretinism. So anything dietary, just put the word endemic before it. One of the things that it causes retardation, if you grow a child and the child has retardation, that might, people might call them a retard, and, the child is gonna have trauma from that. And, failure of body growth. The symptoms, they're not gonna show directly after birth. They're gonna take a few weeks after birth, because the mother supplements thyroid for the first few weeks. If the iodide supplementation is given early, you can prevent the symptom or reverse them. And skeletal growth is inhibited, but the soft tissue still continue. So basically, the tongue is going to be relatively larger than the skeletal muscle. So now, since we have a larger tongue, it can obstruct the breathing and sometimes choke the child. So we're done with the physiology. Let's go to the questions. Read the question. In 1, 2, 3, I'm going to show the answer. It is A, Graves' disease. Why is it Graves' disease? It's the only one of the options that explains why we have an increased T3 and T4 while maintaining a decreased TSH. It is not pituitary adenoma because we have less TSH and T3, T4. It is not in hyperthyroidism. Not, we did not talk about this, and not in thyroiditis because that would decrease it. Now, for thyroiditis, it would increase it, not decrease it. It would increase TSH. Now, for the thyroid releasing hormone, TRH, uh, it goes through G protein coupled receptor. This thing is very, high yield. You're gonna see it in mole. You're gonna see it in this exam or TBL. You're gonna see it in the final again. You're gonna see it in Abdelahad's lecture. You're gonna see it everywhere. G coupled protein receptor. The TRH hormone, the hypothalamic one, goes through which of the following cascades? Now, I'll show the answer in 1, 2, 3. It is phospholipase C. Now, cancel calmodulin because that's, muscle. Cyclic adenylomonophosphate, cancel that too. That's cyclic AMP. That goes to the adenyl cyclates and cyclic AMP. They go to TSH, the pituitary gland hormone, not TRH, the hypothalamic one. And protein kinase A is also part of the TSH one. Now, we have this PTU prevents which step in the thyroid hormone synthesis? Now, 1, 2, 3. The answer is B, iodination and coupling or organification. Now, we mentioned that PTU inhibits peroxidase, and this option mentions the function of peroxidase. You have to know what does PTU inhibit and what does, since it inhibits peroxidase, what does peroxidase do? It doesn't activate the receptor. It doesn't break down thyroglobulin. That's protease. It doesn't cause iodine trapping. That is done by the eight, perchlate, nitrate, and the other eight. Let's go to the next question. Complete thyroidectomy. You get the whole thyroid gland out, performed in a patient, and then you administer that patient with oral thyroxine. Following that, the thyroid stimulating hormone TSH, the pituitary gland one, was normal. Which of the following is correct in the patient? I'm going to show the answer in 1, 2, 3. D. The patient has a decreased synthesis of thyroglobulin. Since we have no thyroid gland, we're not going to synthesize thyroglobulin. But for the other ones, we're thyroxine binding globulin levels. That's done by the liver. We have done nothing to the liver. Thyroxine plasma levels, they're not decreased. We just gave the patient oral thyroxine. Decreased triiodothyronine plasma levels. That's not going to be decreased because T4 thyroxine is going to be changed into T3. Now for this question, I believe this is the last question. This one is very important and I've explained it maybe twice. A patient has goiter, which is hypertrophy of the gland, has high plasma level of TRH and TSH. Heart rate is elevated. The patient most likely has which of the following? I'm going to show the answer in 1, 2, 3. It is hypothalamic tumor. TSH here is kind of misleading. You only need to look at TRH since this is like the major part of the downstream effect. TRH secreted by the hypothalamus. It increases THS, which explains the increase of TSH, and then it increases TH. That's it, everyone. I hope you enjoyed both anatomy and histology by Khaled and physiology by me. Please attend the TBL from inside. Do not take it from outside. Please attend that. Thank you, guys.